cardiac assessment before non-cardiac surgery, and this is a new guideline 2022. And what I will do now, it's a summary for this guideline, and I make it as a clinical pathway, translating this guideline to clinical pathway. I hope I will summarize this in the very concise and summarized and clinical pathway for this huge problem. Actually, the magnitude of the problem, it's very high. The annual volume of major surgery worldwide is estimated to be more than 300 million patients. European Union countries, 20 million major procedure annually. Nearly 85% of major operative are non-cardiac surgery. And in recent report from the USA, nearly half of adult age patients equal or more than 45 years undergoing major non-cardiac surgery, and which is critical. More than 4 million people per year die post-operatively, making the post-operative death is the most common cause of death due to cardiovascular cause. So this is for any patient going to non-cardiac surgery, we will do risk assessment. Cardiovascular morbidity and mortality in patients undergoing non-cardiac surgery are determined by 4 main factors: patient-related risk, type of surgery, timing of surgery, I mean elective versus emergency procedure, and the experience of the institute. Patient-specific risk factors should be identified and optimized during a preoperative evaluation as time permit. A stratification of surgical risk as low, intermediate, high, with patient-specific cardiovascular risk factor collectively inform the approach for cardiovascular testing. When high-risk surgery is planned in patient with high cardiovascular risk, less invasive surgical technique should be considered. Most important point in this guideline, you have to estimate the total risk, not the surgical risk or patient risk. They have to estimate the total risk. And here you can appreciate the bottom left, the patient we are looking, low-risk patient for low-risk surgery. And on the top right, you can consider here high-risk patient for high-risk surgery. And our goal to minimize the risk for high surgical risk procedure for high surgical risk patient. Surgical risk procedure should be stratified into one of the 3 categories: low-risk surgical procedure, intermediate surgical procedure, and high-risk surgical procedure. In low-risk surgical procedure, the 30-day cardiovascular outcome, including mortality, should be less than 1%, and intermediate risk 1 to 5%, and high surgical risk procedure more than 5%. And you have to remember this risk related to the surgery, not related to the patient. Timing of surgery, it's very important because if you will do immediate surgery, definitely the surgical risk, it will be high. So in immediate surgery definition, surgery or intervention should be performed without any delay to save life or organ of the patient. In urgent procedure, surgery or intervention should be performed without unnecessary delay to save life, limb, or organ. Time-sensitive procedure like carotid intervention or cancer surgery, or intervention should be performed as soon as possible, as there is time-dependent risk of losing limb or organ function or increased risk of complication like surgery, as I mentioned, or carotid intervention for patient presented by transient ischemic attack. So there is time window for time-sensitive surgery will vary depending on the underlying disease. Elective procedure, here surgery or intervention can be performed electively, not versa defined the timing, but without significant risk of losing limb or organ function or increased risk of complication. If non-cardiac surgery is time sensitive, so individualized multidisciplinary decision-making should be performed or determined the risk benefit of the cardiac testing and optimizing effort versus ongoing to surgery. Here, the multidisciplinary team, they will decide either to go cardiac testing or to go to the surgery without delay. So this is a responsibility of the multidisciplinary team in time-sensitive procedure. If planned non-cardiac surgery is neither emergency or time-sensitive, so this is an elective procedure. We have time to do accurate history-taking physical examination and to do standard lab testing, smoking cessation, and the guideline-supported medical optimization for all risk factors, including diabetes, hypertension, dyslipidemia, to stabilize heart failure patient or coronary artery disease patient or any kind of arrhythmias. Also, we can summarize the patient-related risk into 3 categories only, and this is very simple. No need to do risk score. Only from the guideline, you can put the patient in 3 categories. The first category, if you confronted by patient with his age less than 65 with no cardiovascular risk factor. So here, the guideline recommending no cardiac testing is recommended before low or intermediate non-cardiac surgery, ECG and cardiac biomarker, including high sensitivity troponin and proBNP, recommended only for high-risk non-cardiac surgery if the age more than 45 years. Transthoracic echocardiography recommended with family history of genetic cardiomyopathy only, and this is class 1 indication, level of evidence A. Second group of patients, if you have referral from our colleague from surgery department and the age of the patient 65 or more, but with cardiovascular risk factor. So here, no cardiac testing is recommended before low risk non-cardiac surgery, but in moderate and high risk non-cardiac surgery, ECG and cardiac biomarker, it is indicated, and class 1 indication. Functional capacity assessment also recommended in intermediate to high risk surgery, and this is class 2 level of evidence A. The last group of patient, if you have referral from any surgical department with any age, but this patient with established cardiovascular disease. Here, in this situation, no cardiac testing again recommended for low risk non-cardiac surgery. ECG and cardiac biomarker indicated class 1 indication, level of evidence A if there is moderate to high risk non-cardiac surgery. Functional capacity class 2A and cardiology consultation with multidisciplinary discussion are recommended in high risk surgery. And this is the algorithm, a very easy algorithm. If you have an emergency, so no need for cardiac testing, you have to proceed for non-cardiac surgery to save the patient life and organs. And if there is time sensitive, as we mentioned, here in this case, multidisciplinary approach, including the cardiologist and cardiac and the surgeon, and to decide which procedure you will do first, either to go to cardiac testing or to go directly to the non-cardiac surgery. So this is the decision of the multidisciplinary team. But in elective surgery, elective non-cardiac surgery, we have time. You have to do clinical assessment, history taking, clinical examination, and you have to categorize the patient in the 3 group as we mentioned. So this is a preoperative assessment in patient with newly detected condition, like if you will examine the patient and you detect a murmur on the heart. So in this situation, the recommendation of the guideline, echocardiography is recommended, class 1 level of evidence C, and if the murmur suggesting clinical significant pathology, class 1 level of evidence C also. Transthoracic echocardiography also may be considered if absent of sign and symptoms of cardiovascular disease before intermediate and high risk non-cardiac surgery. For any patient who developed the peripheral edema, in this situation, the guideline recommending ECG and proBNP, and this is class 1 indication, level of evidence C, and if there is elevation of proBNP, echocardiography is recommended, class 1 indication, level of evidence C. For any patient who has no history of coronary artery disease, but he is complaining from chest pain, so here the guideline recommending to do cardiovascular workup, and this is class 1 indication level of evidence C. Multidisciplinary assessment is recommended prior to urgent non-cardiac surgery. And this is very nice stress testing protocol, and this is high risk feature for all stress modality, including exercise test, SPECT or bed perfusion imaging, stress echocardiography, cardiac MRI, coronary CT, invasive angiography. So if there is significant ischemia in all this stress modality, including CT and invasive cardiology, invasive coronary angiography, if there is any significant ischemia, mainly in the left main or LAD, you have to do revascularization for this group of patients before non-cardiac surgery to minimize the perioperative MI and sudden cardiac death. And this is the management of patients who presented by coronary artery disease with documented ischemia. If there is significant ischemia by stress modality, more than 10% of the myocardium, in patient who is going to elective non-cardiac surgery, so postpone non-cardiac surgery and do revascularization before non-cardiac surgery. Also, in patient, if the patient develop the acute MI, definitely we will follow the algorithm of acute coronary syndrome. For patient perspective, definitely clear and concise written and verbal pre and post operative medical instruction should be given to the patient prior to cardiac surgery. Structured information list should be considered in patient with high cardiovascular risk prior to non-cardiac surgery. This is the most common question asked by the patient, explaining who will take care of me, cardiologist or surgeon, where I will be, ICU or CCU or telemetry or regular wards, and who will give me the cardiac medication, who will take care of me, and who will give me the medicine for cardiology or cardiac care before and during and after the procedure. Frailty assessment, it's very important, and use of validated frailty assessment tool prior to non-cardiac surgery is recommended in patient equal or more than 70 years, and this is class 2 level of evidence C. For preoperative thromboprophylaxis decision making, this is very important, and you have to follow all the VTE prophylaxis protocol to minimize the risk of peri and post-operative DVT and pulmonary embolism. For blood management, this is very important, mainly intraoperative, and this is very important. You have to use closed loop blood sampling and use point of care diagnostic testing inside the OR. And here also the blood saver, I mean use of wash the cell salvage, I mean auto transfusion. This is very important to reduce the blood transfusion, and this is class 1 indication level of evidence A. And the most important medicine to be available in the ER, which is tranexamic acid, and should be given to all patients who develop the bleeding intraoperatively to minimize the blood transfusion and to minimize the cardiovascular risk. For patients with heart failure undergoing non-cardiac surgery, regular assessment of volume status and organ perfusion during the procedure. This is class 1 indication. For patient with valvular heart disease, definitely if the patient, he will do elective non-cardiac surgery, low risk elective non-cardiac surgery, even if there is severe valvular heart disease, keep this patient to do the low non-cardiac surgery. But if there is significant severe mitral stenosis, mitral regurg, severe aortic stenosis, severe aortic regurg, for patient going to elective non-cardiac surgery, you have to do intervention for aortic stenosis, aortic regurg, mitral stenosis, mitral regurg before the procedure. The only exception for severe valvular lesion if you will do non-cardiac surgery, and this is clear from the guideline as regard the management of severe valvular lesion before non-cardiac surgery. To make it simple, severe symptomatic aortic stenosis, aortic regurg, severe mitral stenosis, mitral regurg, for elective non-cardiac surgery, treat the valvular lesion before the procedure. But if there is urgent procedure, low risk non-cardiac surgery, you can proceed. For moderate risk surgery, high risk surgery, elective with severe valvular lesion, you have to do valvular intervention before the procedure. For patient with cardiac arrhythmias, very important. For patient who develop atrial fibrillation, you have to plan this patient for TEE guided cardioversion to minimize the anticoagulation and to reduce the bleeding related to anticoagulation. For patient who develop symptomatic bradycardia and indicated for pacemaker, do the pacemaker before non-cardiac surgery. For patient who develop the ventricular tachycardia, not responding to medical treatment, and he will do moderate to high risk non-cardiac surgery, send this patient to electrophysiologist to do EBS and ablation before non-cardiac surgery. And for a patient who already implanted devices like pacemaker, AICD, CRT, CRTD, the electrophysiologist should be involved for programming and reprogramming for this pacemaker before the procedure. For the electric cautery, you have to do very short electric cautery and to be far away from the electric circuit of the pacemaker or implantable device. Perioperative biomarker, the guideline recommending clear message. Cardiac biomarker, including high sensitivity troponin, proBNP, D-dimer, should be done for intermediate to high risk non-cardiac surgery patient, and the aim to do the high sensitivity troponin for early detection of early post-operative myocardial infarction. And the cardiac troponin, they are concentrating to do it 1 day before the procedure, and the first day after the procedure, second day after the procedure, to compare if there is any significant delta change and increase of the cardiac troponin or not. proBNP should be done once before the procedure, and this should be for high risk or intermediate risk non-cardiac surgery. But in elective low risk non-cardiac surgery, no need to do cardiac biomarker. And by use of this troponin, you can detect if there is myocardial ischemia or myocardial infarction. And this is a very simple algorithm to proceed for this detection of myocardial ischemia or myocardial injury related to type 2 MI. Antiplatelet, very common referral from all the non-cardiac surgeon if the patient did angioplasty and the stent, and the patient on dual antiplatelet therapy. So what we will do in this case, the patient should be assessed by cardiologist. And if this patient did elective BCI with drug-eluting stent, so it's better to keep the patient on dual antiplatelet therapy for at least 1 month. Then you can stop the Plavix and to continue B2Y12 inhibitor to do the procedure. If drug-coated stent in elective, 3 months, and if drug-coated stent in SES patient should be 12 months. And it's not allowed to quit one of this antiplatelet agent before the procedure. But if the patient, he will do urgent non-cardiac surgery and still the patient on dual antiplatelet therapy after stenting in acute coronary syndrome, so here in this situation, the guideline recommending to do bridging. And here for the bridging for antiplatelets, it is very important to inform the team involved in the care, either in the ICU or coronary care unit or in the unit. It's not allowed to do bridging by Clexane, I mean unfractionated heparin or fractionated or heparin, because the heparin, it will increase the platelet activity and it will increase the platelet activation and to increase the thrombotic risk. The only available medicine to do bridging by intravenous glycoprotein 2B ester inhibitor or cangrelor. It's not recommended at all to use bridging using unfractionated heparin or low molecular weight heparin. Oral anticoagulant like heparin, like Coumadin or NOAC. Also, you have to balance the bleeding risk and ischemic risk. If the surgery carry low bleeding risk and the patient also low ischemic risk, you have to quit the anticoagulation without any bridging and to proceed for surgery. But in case of high ischemic risk, like patient with SHAD VASCO score with atrial fibrillation more than 2, and there is prosthetic metallic mitral valve or aortic valve, here in this situation, you have to do bridging by unfractionated heparin or low molecular weight heparin, and to stop this medication 6 to 12 hours before the procedure. So other topics addressed for first time in the European Society of Cardiology Guideline 2020, the hypotension. If any patient who developed intraoperative hypotension, you have to differentiate between if there is simple hypotension or circulatory failure secondary to the bleeding. This is very important. The guideline recommending clear assessment for perfusion and to differentiate between simple hypotension and the acute circulatory failure secondary to the bleeding during or post-procedure. Another issue raised in this guideline, cancer patient undergoing non-cardiac surgery, special attention to cancer patients population is warranted due to increase the prevalence of comorbidities related to cancer and cancer treatment. There is increased risk of thrombosis due to malignancy and cardiotoxic chemotherapy for this group of patients. Last group of patients, which is non-cardiac surgery in patient with COVID-19 infection, and it's clear from this message, registry data shows an increase in morbidity and mortality if non-cardiac surgery take place less than 7 weeks from the time of COVID-19 diagnosis and treatment. This data were collected from unvaccinated patients, and the relationship to recent COVID-19 diagnosis and post-operative outcome among vaccinated patients is still currently uncertain. Persistent symptoms of dyspnea, chest pain, fatigue are cited as factors increasing the risk of post-operative mortality regarding of the timing or relation to COVID-19 infection. Thank you so much for your attention, and I'm ready